A very good evening, guys. Very good evening. So, welcome to the platform of eGurukul and Dr. Bhatia Medical Coaching Institute. I am Dr. Ramyashree. I teach obstetrics and gynecology. So, in this session, it's a doubt solving session. So, whatever are your doubts, you can feel free to ask. Very good evening. So, this is the doubt solving session. So, you can ask your doubts. If you don't have doubts, then we will do some MCQs in this session. So I'll be first waiting for your queries and followed by we will start the MCQs. So till you start with your queries, I'll start with the questions. So we'll utilize this 1 hour for solving MCQs, right? Very good evening, Arvindan, Ravi, Jai Mohan, Sanchi. Very good evening. So the very first question what we have is, yes. So identify the position of the baby in the picture. So always while you determine the position, I always ask you to first tell right and left. Think what is the denominator, then decide what is the position. So if you observe the mentum is here, you observe the mentum is here. So here the presenting part is face. So it is right. No, the mentum is towards the left side. The mentum is towards the, which side is the mentum? Mentum is first and foremost towards the left side, right? Always remember your right and patient's right is ulta. So this is the right of the patient and this is the left of the patient. The denominator is the mentum and the denominator is towards the left side. So this is, and it is towards the pubic symphysis. Whenever the denominator is towards the pubic symphysis, you're going to call it as anterior. So what is the answer now? It is left mento anterior. It is left mento anterior, right? Very good. So I see only some of you answering correct. Okay, one more we'll do. I think you would have seen the answer actually, but yes, still. So can you try for this picture? So what is the presenting part for this picture? I think answer was C, no? So this is the occiput. So occiput is right side and it is towards the ischial spine. So this is right occipitotransverse. The right occipitotransverse. So they can give any of the position. You should be in a position to answer. Yes. So I have a query here from Sanji. So quadruple marker or any screening methods are positive. Even NIPT is positive. Your next step should go for confirmation with invasive test. If that is also abnormal, then you will go for termination. Okay. In left oblique breech presentation, head engages in which direction? So to be frank, so in breech, there is cardinal movements happening at the level of buttocks. So at the level of buttocks, it is the bisacromial diameter, followed by there will be rotation of the shoulders. Sorry, first at the level of buttocks, it is not bisacromial, it will be bitrochanteric diameter. So there should be engagement of three things in the breech. So first bitrochanteric diameter will engage. So first the bachcha's buttocks will engage, right? So if it is left oblique breech, it is engaging through left oblique. Same way where the breech buttocks are engaging, same way bisacromial diameter also will engage. But head will engage in the opposite direction, guys. If the breech is engaging in left oblique, head will engage in the right oblique. Head will engage in the right oblique. Okay. So breech may, if left oblique breech presentation, by trochanteric diameter and bisacromial diameter, that is buttocks and the shoulder will engage through left oblique, but head will engage in the opposite direction, that is right oblique. Okay. So next I have Jangir asking me endometriosis may cystectomy and aspiration. So whenever you have endometriosis and if patient wants to conceive, and if the cyst size is less than 3 centimeters, then you will go for cyst aspiration and ablation of the cyst wall. But if the cyst size is more than 3 centimeters, you go for cystectomy. Okay. Only if the size is less than 3 centimeters, you can go for it. But if it is more than 3 centimeters, you'll directly go for cystectomy. To be frank, in the practice, we don't do aspiration. Aspiration is somewhat outdated. Okay. Next, breech presentation with hydrocephalus is managed by. Now this I am expecting you people to answer. Breech presentation with hydrocephalus will be managed by Cesarean section, transabdominal decompression, PV decompression, craniotomy of the aftercoming head. Yes. Very good, Shweta, Dr. S. Excellent. So whenever you have breech presentation with hydrocephalus, you cannot, whenever we have fetal anomalies which are incapable for vaginal delivery, you should directly go for Cesarean section. Yes, excellent, Roy, especially if the baby is alive. If baby is dead, you can do vaginal delivery for this baby. But if baby is alive, you have to go for Cesarean section. What are the two other types of breech where we go for Cesarean section? What are the two types of breech where we go for Cesarean section? Elective Cesarean section. So footling breech and stargazing breech, we go for elective Cesarean section, right? Next question. 30-year-old multigravida presents with transverse lie with hand prolapse in second stage of labor. In second stage of labor with dead fetus. What will be the treatment for this patient? So understand here, it is a 30-year-old multigravida with transverse lie, but there is hand prolapse. So baby's hand is prolapsed outside. So now how will you manage her? So will you do classical cesarean for her? Will you do lower segment cesarean section? Will you do craniotomy? Will you do decapacitation? Will you do cleidotomy? Yes, Rahul, I'll tell you a brief about the cancer cervix management. So nowadays, first and foremost, these all are destructive operations. That is craniotomy, decapacitation, cleidotomy. All these are destructive operation. In modern obstetrics, we don't do destructive operations. Okay. As it is a hand prolapse, the baby would have been edematous. It's completely stuck. and you cannot remove this baby in the lower segment cesarean section also. So whenever you have only this case, transverse lie with hand prolapse, you require to go for classical cesarean section. So transverse lie with hand prolapse is an indication for, one of the indication for classical cesarean section, because baby would have been edematous, so it would have been stuck there. So it's very difficult for you to remove the baby either vaginally or lower segment cesarean. So classical cesarean means you are taking the incision on the upper segment of the uterus. Whereas lower segment means we do Kerr's incision, which is a transverse incision in the lower segment. Okay. When in labor, a diagnosis of occipito-posterior presentation is made. The most appropriate management would be when in labor, a diagnosis of OP presentation is made. The most appropriate management would be emergency cesarean, wait and watch for the progress of labor, early rupture of membranes, start oxytocin drip. Excellent. So the answer here will be wait and watch for the progress of labor. So why in occipito-posterior presentation we are doing wait and watch for the progress of labor? Who can tell me the reason also? Because even when it is occipito-posterior, 90% of the babies can rotate 3/8 of the circle. 90% of the babies can rotate 3/8 of the circle. Or sometimes if it is direct occipito-posterior, it can deliver as face to pubis. So there is definitely chance of vaginal delivery. So that is why we are waiting and watching. Okay. So OP position is not at all an indication for emergency cesarean. So what is the maneuver given in the image below? I think very easy, direct question. What is the name of the maneuver which is given in the image below? Pinard's, Ridgen, Brandt's, Andrew, manual removal of the placenta. So this is nothing but the Brandt's Andrew method or control cord traction. So when you put one hand on the abdomen, with another hand you hold the cord and try to pull it out. This is Brandt's Andrew method. Okay, next question. A 25-year-old woman whose antenatal period was uncomplicated is in labor. She has a single fetus in cephalic presentation. Good. Head is not engaged. Normally, when does engagement occur? So, primigravida engagement takes place at 37 weeks. Multi-May, it will take it at the onset of labor. So, first point which should strike your brain that something is wrong here is when head is not engaged yet. Okay. Fetal heart rate is 130 beats per minute. Cervical dilatation is 5 centimeters. So she's already 5 centimeters dilated. In spite of that, the head is not engaged. Membranes are absent. Pelvis is adequate. It is decided to perform cesarean section immediately. Which one of the following is the most likely cause for this decision? So what do you think might be the reason for such emergency cesarean section in this patient? Approximation of suture lines. What do you mean by approximation of suture lines? So everything was going on well. Suddenly you have decided to do cesarean section and they are asking you what might be the reason for this sudden decision of cesarean section among these four options. So first option is approximation of suture lines. So approximation of suture lines is nothing but molding. So we actually have 3 grades of molding. Approximation of suture lines is grade 1 molding, which is physiological. So no need to do anything. Now I want you people to tell me palpation of the anterior fontanelle and sagittal suture means it is which position? what position I taught you today, where we'll have a palpation of anterior fontanelle and sagittal suture. So palpation of anterior fontanelle and sagittal suture suggests that we are dealing with, this is the occipito-posterior position. Occipito-posterior also doesn't tell that you have to suddenly go for cesarean, because just now we told that she can progress into labor, right? Palpation of eye, nose and mouth suggests that we are dealing with face. Face, mento anterior, you can always do vaginal delivery. Palpation of frontal bones and supraorbital ridge. So, where do we palpate frontal bone and supraorbital ridge? It is bro. Can bro ever come out from the pelvis? Can bro ever come out from the pelvis? No, because what is the engaging, how many centimeters is the engaging diameter for the bro? So I think most of you know my mnemonic for the engaging diameter. So it is bro move 14th Feb. So bro mento vertical 14 centimeters. So bro can never come out of cervix or the pelvic cavity. So that is why here, although it is cephal 5 centimeters dilated, you are taking a sudden decision to do for cesarean section because you have palpated bro. So the answer here will be D, right? A gravida 2 para 1 living 1 presents with full term pregnancy with transverse lie at 36 weeks. On examination, membranes are intact. Fetal heart sounds are regular. What would be the appropriate management in this case? So, normally whenever you have a transverse lie, she has come to you at 36 weeks. What will you do for her? So, even in transverse lie, when the patient comes to you from 36 weeks to term, you can always try for external cephalic version. So as she has come to me at 36 weeks, she's not in labor, membranes are intact. So she's fulfilling all the criteria for the external cephalic version. So that is why here we are going to go for external cephalic version. Okay. Never wait and watch for spontaneous expulsion and evolution in transverse lie. It will never come out. Very rare. That too, it will result in a dead fetus. So as it is a transverse lie, membranes are intact, fetal heart sounds are good. So you do try ECV. But if same question I would have given, if the patient is in labor, transverse lie with labor, then what will be your answer? So if it would have been transverse lie in labor, then what will be your answer? So if you have transverse lie in labor, then you will go for direct cesarean section because ECV cannot be done in labor, right? So to summarize, very good, excellent. All of you are answering correct. So whenever you have transverse lie, always first try ECV from 36 weeks till term. If this fails, then you will go for vagina LSCS, lower segment cesarean section. So in normal transverse lie, you will do lower segment cesarean section itself. So while you are doing lower segment cesarean section, how are you going to extract the transverse lie baby? Are you going to extract the baby by breech or are you going to extract the baby by head? So this was asked as an MCQ once in the INI-CET or not NEET, but it has been asked. So you have to extract the baby by legs, not by head, because head can skip. We don't get a proper grip, but legs can aram se we get a better grip. So we extract by legs. Okay. So lower segment cesarean section, and baby is extracted by breech. So it's a relative contraindication to do ECV when patient is in labor, although membranes are intact. It's not like an absolute contraindication, but it is a relative contraindication to do ECV when patient is in labor with membranes intact. Critical obstetric conjugate for trial of labor is. This is a direct question. Yes, I'm expecting you to answer. Critical obstetric conjugate for trial of labor is 8.5, 9, 9.5, 10 centimeters. Yes. So critical obstetric trial of labor is trying for vaginal delivery in mild inlet contraction. So when obstetric conjugate is 10 centimeters, normally it is 10.5. So 0.5 centimeters reduced. So when obstetric conjugate is 10 centimeters, we call it as critical obstetric conjugate, where we can still do trial of labor. 10. Answer is 10. Okay. Benefits of surgical induction, that is artificial rupture of membranes, are all except. So lowers the blood pressure in preeclampsia, relieves the maternal distress in hydromenos, decreases the incidence of amniotis, reduces the need for cesarean section. So artificial rupture of membranes you do whenever there is a bag of water and you want to augment the labor. So usually it is better to do in the active phase. So or when cervix is more than 4 centimeters dilated. Early ARMs are more prone for infection, right? So in patients with preeclampsia, ARM can decrease the blood pressure. Controlled ARM can relieve the maternal distress in polyhydramnios. It reduces the need for cesarean section by augmenting the labor, but it does not decrease the incidence of amniotis. It increases the incidence of amniotis. So C is the wrong statement. Right. Which one of the following methods for induction of labor should not be used in patient with previous lower segment cesarean section? Prostaglandin tablet, prostaglandin gel, stripping of membrane, oxytocin drip. So you should never use misoprostol, which is a prostaglandin tablet. So prostaglandin tablet or the misoprostol is an absolute contraindication for induction of labor in a patient with previous lower segment cesarean section, as we have the risk of uterine rupture. Okay. So misoprostol causes uterine rupture. So that's why you should not use this for induction of labor in previous LSCS. What is the pressure inside the uterus during second stage of labor? 100 to 120, 200 to 220, 300 to 400, 25. Arun, in single, so I have a query here from Arun that in single umbilical artery, renal anomalies are more common or cardiac. In patients with single umbilical arteries, cardiac are slightly more common than renal. Cardiac. Yes. So the pressure inside the uterus during the second stage of labor is 100 to 120. First stage of labor, it will be 50 to 60. Second stage of labor, it will be double, that is 100 to 120. The pelvic assessment by vaginal examination of a pregnant woman is best done just after the first missed menstrual period, at 37th week of pregnancy, at 28th week of pregnancy, at the onset of labor. So the pelvic assessment by vaginal examination of a pregnant woman is best done just after first menstrual period, at 37th week of pregnancy, at 28th week of pregnancy, at the onset of labor. So the pelvic assessment by vaginal examination ideal is to be done at the onset of labor. So at the onset of labor, it releases relaxin. It releases relaxin which causes relaxation of the ligaments. So that will give you the absolute findings of the pelvic adequacy. Okay. When the fetus is in attitude of partial extension, what should be the mode of delivery? So first and foremost, what do you think attitude of partial extension means? So when the fetus is in the attitude of partial extension, what is the mode of delivery? Vacuum delivery, forceps delivery, LSCS, normal vaginal delivery. So partial extension means I want you to tell me what does attitude of partial extension means first. So attitude of partial extension means we are dealing with very good Shravani, excellent. It is a bro presentation. It is the bro presentation, right? So bro presentation LCS. So it is just the framing of the question. All of the following are contraindications for trial of labor, except you can answer this question once you know what is trial of labor. So what did I tell you? What is trial of labor? Trial of labor is trying for vaginal delivery in a mild inlet contraction. है ना? So you're trying for vaginal delivery in mild inlet. So obviously outlet contraction is a contraction is a contraindication. Breach, normal pelvis only we are scared. Normal pelvis itself we are scared that whether the pelvis will ever come out or not. How will we decide whether it will come out in trial of whether it will come out in contracted pelvis, right? So it is not we cannot do trial of labor in breach also. Previous stillbirth also we should not do trial of labor. Previous stillbirth also we should not do trial of labor, right? Because in a patient with previous stillbirth, what is she more bothered about? She is more bothered whether she is having a normal baby or not. Whether she's having a normal baby or not. She's not bothered whether you're going to do cesarean or vaginal delivery. And trial of labor definition is itself, you are doing a mild inlet contraction. So it is not going to be a contraindication. So that is why the answer here is C. Okay. Right. Okay, so I think all of you are answering correct. Very good. Let us go to the next question. A 32-year-old woman, 37 weeks, in her first pregnancy, is admitted for induction of labor. As her baby has ultrasound confirmed IUGR. So whenever baby is less than third centile, we call it as IUGR. In early labor, CTG shows a baseline rate of 150 beats per minute, variability of 5 beats per minute, infrequent variable deceleration. Now, how many of you know regarding the CTG? What do you think is variable deceleration? So, variable deceleration is something where the deceleration is not coinciding with the contraction. So variable deceleration is seen with cord compression. So there is infrequent variable deceleration, dropping the baseline by 60 beats per minute or less and taking 60 seconds to recover. This has been recorded by over previous 45 minutes. Irrespective of whatever you know about CTG, do you think these findings of CTG are normal or abnormal? So definitely this is abnormal. Right? So there is a definite cord compression. She is contracting once every 10 minutes and cervix is dilated 1 centimeter, 2 centimeters long. What is the most appropriate next step? Actually, answer is very easy, no? Anything goes wrong, you can always go for a cesarean section. And here there is a definite indication where baby's heartbeat is dropping so much. And if you do ARM, further it will drop down, right? And you cannot continue monitoring. Already you have continued for past 45 minutes, right? You cannot induce her because it's a bad CTG. Whenever you're inducing, you will first do CTG and then induce. If it is a bad CTG, we avoid induction. So perform an immediate cesarean section. Okay. All are true regarding the origin and propagation of contractions except all are true about the origin and contraction of the contractions except rate of spread of contraction is 2 cm per second. Right cornu pacemaker predominates over the left. Intensity of propagation is greatest at the fundus. Contraction spread from cervix to fundus. I am expecting all of you to answer this. So normally the contractions start at the cornu. They start at the cornu. Yes, right pacemaker is little more predominant than left. So this is correct. Contraction spread 2 cm per second. Obviously, intensity of propagation should be more here. Only then baby can go down. Do you want the baby to pop out from the abdomen by piercing and rupturing the uterus? No, you want it to come from down. So the contraction should spread from fundus to cervix, not cervix to fundus. So D option is wrong, right? Next question. A 34-year-old primigravida is admitted in spontaneous labor at 39 weeks of gestation. Clinical examination suggests an average size fetus. In cephalic presentation, cervix is 2 centimeters dilated. The membranes are absent. Epidural block is cited. Oxytocin infusion is commenced because contractions became infrequent. After a further of 9 hours, she is found to be fully dilated. 1 hour later, vaginal examination is repeated. The presenting part is at the level of ischial spine plus 2. Position is left occipitotransverse. Presenting part is not palpable per abdomen. What is the management? So, very big question, right? Okay, so I see most of you answering for B here. Let us understand this question. So first and foremost, before we answer this question, patient is in which stage at the end when we are trying to solve this question? Is she is in first stage or second stage or third stage? Just tell me that point first. So she is in which stage of labor? First stage, या second stage, या third stage? Wonderful thing is, all of you have answered between A, B and D. She is in second stage. So whenever you get a question on labor, you should ask yourself first ki she is in which stage. Whether she is in first stage, latent or active phase, whether she is in second stage or whether she is in third stage. Then your brain should go towards the tables which I made you write. Okay? So as she is in, yes, it's always better to read from the end. That is 100% correct, Roy. Actually, if you observe in this question also, the first half of the question is like just a story. I am okay 2 centimeters from 9 hours, she became full and all. Because now what I'm more bothered is when she is full, what is happening? And for me to retain in my brain is from here to here. So that is why last part of the question is always important when you have a big question. Because first half will be just a story. Okay? So here last part only is important again to us. So in the last part, we have found that she is a primary who is in second stage for past 1 hour. Right? And she is also having epidural along with her. So now let us go to the table of the second stage of labor. So whenever the patient is in second stage, primary, multi, average duration, prolonged second stage, and second stage arrest. Guys, did you all watch all the updated videos? Because I made all the updated videos free on the YouTube. So watch the WHO labor care guide, watch antenatal updates and the last updates regarding the abortion, diabetes, preeclampsia. So I compiled all the updates at one place. So do watch all these 3 videos on the YouTube, guys. Okay. So now here, so primary mein, I want you to remember that it is 1, 2, 3. Next 30 minutes, 1 hour, 2 hours. With epidural, for everything here, it will be plus 1 hour. So, she already completed 1 hour, but it is still fine. You can wait for another 1 hour, right? For her to deliver vaginally. When will you apply forceps or vacuum? When she is more than or equal to 2 hours. When she is more than or equal to 2 hours. Actually, as she is having epidural, you have to wait for more than or equal to 3 hours. So you have to wait for another 2 hours before you apply the forceps or vacuum in this patient. Right? So what is the answer here? So as she is a primary, and she is being fully dilated only from 1 hour, and as she is having epidural, you can wait for another 2 hours. So the answer here will be C, encourage maternal efforts. So to be frank, there are like very few. First half to everyone have answered A, B, D. Last pay I have Divya and Maria answering C. So the answer here is C. Yes. Okay. So now I will take up the query. Somebody asked me to tell cervical cancer management. So did you understand the possible questions which can be asked in labor and how to answer? Right? So somebody asked me to tell about the cancer cervix management. I'll tell you one very, very simple way to remember the cancer cervix management. So cancer cervix may you can do radiotherapy for all stages. But always surgery is preferred over radiotherapy because you can save the ovaries and you can save the vagina. Right? From stage 1A1, keep the A1 constant. 2, right? 1 ke baad it is 2, no? So 1A1 to 2A1 except 1B3. you can do surgical management. And that too in surgical, you mainly do hysterectomy and lymph node dissection, but you never touch the ovaries. You don't remove the ovaries in the surgical management of serious CS cervix. From stage T8, 2A2, 2-4 and 1B3, you will do concurrent chemoradiotherapy. That is, you can give cisplatin followed by either brachytherapy or intensity modulated radiotherapy. Simple. If you remember this much, you can crack most of the questions which are asked in the CS cervix regarding the management. Very simple. For last minute, these are the best pearls which you can take. Right? One more question we'll do. A 37-year-old primigravida attends the labor ward complaining of irregular contractions. 37 primigravida. Is that combination apt, guys? Is that combination fine? (37) and primigravida. Is that combination fine for all of you? Definitely not. So 37 weeks old primigravida means she's an elderly primigravida. She's an elderly primigravida. She is 38 weeks pregnant. The ultrasound scan performed at 36 weeks showed that placenta to be posterior and high with a normally growing baby. She conceived by IVF, expected actually, right? Elderly primigravida, most likely to be IVF pregnancy. Her admission CTG shows baseline 145. Remember guys, baseline should be between 110 to 160. So baseline of 145 is absolutely normal. Variability should be between 10 to 25 to 25, so 10 to 15, good. There are axials and no decelerations. So on the whole, her admission NST is absolutely normal. She is contracting once every 10 minutes. Vaginal examination shows cervix to be partially effaced, dilated 2 centimeters with intact membranes. Head is 5/5 palpable. When entire head of the baby is above the pelvic brim, you call it as 5/5 palpable. So this is the pelvic brim, this is the baby's head. So when entire baby's head is above the pelvic brim, then you call it as 5/5 palpable. If head goes little inside and only 4 fingers of mine are able to palpate the baby's head, I call it as 4/5. If baby's head further goes inside and I palpate, only 3 fingers of mine can palpate the baby's head, 3/5. If it goes further inside and only 2 fingers are able to palpate, then it is 2/5. If you can't palpate the fetal head at all and entire head has gone inside, then it is 0/5. Okay. So 5/5 means entire head is outside. All our observations are normal. Which of the following should be next? Now don't jump into the answer. Okay, I told you don't jump into the answer. Okay, is elderly primary itself an indication for cesarean section always? Precious baby is not an... I'm not asking what we do in our practice. I'm asking you for the purpose of MCQs. So, as our CTG is absolutely normal, there is no indication for performing the cesarean section now. Admit her to labor ward and perform ARM? Absolutely no. You will never perform ARM when she's 2 centimeters with bad. ARM should be used only for augmentation, not for induction. Continuous fetal monitoring means continuously you're keeping the CTG. So that is also not required. But you can just admit her to the antenatal ward. Why? As she is a precious pregnancy, is she having true labor pains or false labor pains, guys? Continuous means non-stop you are keeping. She cannot move at all. So you admit her to antenatal ward because she is a precious pregnancy and she has false labor pains. If suddenly her membranes rupture, then there can be risk of cord prolapse. So ideally you will not admit such patients into the labor room or the ward. But this patient I am admitting because she is a precious pregnancy. Okay, understood, guys? Okay, so I request you to watch the WHO labor care guide definitely, guys. So I have a query here from Kirtana. So Kirtana, according to WHO labor care guide or according to our previous also, whenever the patient is in active phase of labor, you will do PV every 4 hours. Remember, in active phase of labor, you will do PV every 4 hours. When patient is in labor, you will always do PV every 4 hours. Okay. Next question. 34-year-old nulliparous woman is in the second stage of labor. Patient has been pushing for last 2 hours and is exhausted. CTG is normal. Head is 1 centimeter above the ischial spine. Which of the following would be most appropriate action? Guys, already I have answered, I've already answered one question for you, right? So I want you to answer this question. So again, ask yourself, she's in which stage of labor? Again, ask yourself, she's in which stage of labor? No, I want you to go in approach, proper approach. We'll not go to the answer. First, tell me she's in which stage. Second, you tell me she's in what is the diagnosis here? And then we will go for the management. So she is in second stage of labor as the patient is full. Already they only gave she's in second stage. What I'm asking, right? Okay. And she's a nulliparous, so primary. So primary nulliparous, she's been pushing for last 2 hours. Then it means it is a prolonged second stage. Prolonged second stage. Then immediately our head should go for the table of the prolonged second stage. So prolonged second stage, the management depends on the station of the fetal head. So when head is 1 centimeter above the ischial spine, it is vertex minus 1. If the head is above plus 2, you go for LSCS. If head is below plus 2, you go for vaginal delivery. So as it is vertex minus 1, you have to, so vaginal delivery can be forceps or vacuum, right? So as it is head above plus 2, so you're going for LSCS. So emergency cesarean section. Right? All of you understood how the questions can be asked and how you have to approach. So very similar to this question was given in your NEET also. So they'll definitely give you some lengthy questions, but it should be a cakewalk for you when you practice like this. So every month I'll be coming with one doubt solving where I'll discuss some MCQs like this. You can tell me the topics which you want to practice more MCQs so that I can do more MCQs on those topics, and any other videos which are required for you for your exam. Let me know. I'll do that video and also post for you all. So till your exam, let us work very hard so that we can get our dream branch and dream college, right? Okay, so any other queries, guys, before we end today's session? Yes. So regarding the station of the fetal head, so whenever the baby's head is at ischial spine, at ischial spine. Whenever the baby's head is at the ischial spine, it is the 0 station, right? If the baby's head is above, so 1 centimeter above, -1, 2 centimeter above, -2, 3 centimeter above, -3. If the baby's head is below, 1 centimeter below, +1, 2 centimeters below, +2, 3 centimeters below is +3. Okay. No hassle. Patient being exhausted is not an indication of LSCS. If this same patient, station would have been +3. Now imagine if this same patient, same question, let us change little. Same question, head is 3 centimeters below the ischial spines. Then what will be your answer? Ananda, the last one but question which I showed, yes, cervical dilatation of 2 centimeters, but still it is like latent phase. So latent phase, you'd never require to go for LSCS. Latent phase, we can always wait and watch. Even if you take it as latent phase, we can wait and watch. Right. So when it is head is 3 centimeters below the ischial spines, so it is at the vulval outlet. So you can just put the forceps and pull it out. Right. So you can just take the baby, take the trial of forceps and pull it out. Right. Definitely, Harish, that we can take it because we follow the universal precautions. And when retrovirus positive, I think it's always better for going for medical branches than surgical branches. So forceps will be better in this patient because for her already she is exhausted, and forceps bearing down efforts are not required. So even if mother is exhausted and lying down, you can put a forceps and pull the baby out. Okay. Yes, Harish, they can. Next, 34 weeks is about 8 months antenatal ward is the right option. Vaginal discharge in pregnancy. So normally vaginal discharge in pregnancy will be thick and scanty. You normally don't see much vaginal discharge in pregnancy. Physiologically, it will be thick and scanty. Why it will be thick and scanty? Because of the progesterone. But there's one infection which can be predominant in pregnancy, that is candidiasis. So candidiasis can be seen in pregnancy because candida is the only organism which can grow in the acidic pH. So candidiasis is most common vaginal discharge in pregnancy. So candidiasis patient will present to you with curd-like discharge, lot of pruritus. Okay. So any other queries, guys? Yeah, this last question. Identify the procedure shown in the image. Leopold's, Mac Roberts, Pollock's, fundal palpation. So thumb on one side, 4 fingers on other side. This is the Pollock's grip or Leopold third maneuver or Leopold third maneuver. Many times asked as an MCQ. So this will tell whether the presenting part is engaged or not engaged. If the head is ballotable, it is not engaged. If presenting part is not ballotable, then it is engaged. Right? So this is the Pollock's procedure. This is not fundal grip. Fundal grip mein hand should be above. So this is the fundal grip. So this is the fundal grip or the Leopold first maneuver. This is the lateral grip or the Leopold second maneuver, right? Where you are feeling the lateral aspect of the abdomen. This thumb on one side, 4 fingers on other side. This is the Pollock's grip or the third maneuver. You are trying to see whether the hands are converging or diverging. This is the fourth Leopold maneuver or the pelvic grip. So thank you guys. All the best. Good night. Sweet dreams. Work hard. Any issue, any problem pertaining to obstetrics and gynecology, I'm always there to help you all. And I'll definitely message me, I'll revert back to you. And you can also follow me on my Insta, that is Dr. Ramyashree 7, or you can also message me on the DBMCI Facebook Premier group. You have to just tag me, I'll answer back. Right. So thank you guys. Thank you so much. I hope you all enjoyed the session. Thank you.